This is a film interpretation session. Film interpretation session was started in USA, United States of America, and then several nations are following, several state and national radiological societies are also following. Actually, film interpretation session is not a quiz. It is to teach the students how an expert approaches a film. Given a short, brief history, how does he approach the film? What does he find, radiological findings, and then how does he interpret in pathological terms, and what will he the differential diagnosis, and ultimately the final diagnosis, what he thinks it is. That is what is called film interpretation session. And then he may also suggest further investigations. Say, plain film of the chest, there is a shadow in the right upper lobe. And then can he give a final diagnosis? No. Then he may ask for a lateral or an oblique or a CT or an ultrasound to know whether it is cystic or solid, or MRI, depending upon the appropriateness of the situation. Let's proceed. 42-year-old gentleman complains of pain in the hip as well as in the right elbow. And this is the film. How do you approach this film? One, as we see it, there is large acetabulum, mega acetabulum I can call it, because of the erosions. And then complete resorption of the head and also most of the portion of the neck of the femur. So with this, what will be the diagnosis? What is the resorption due to? It's due to corticosteroids, but this much of resorption is unusual. And then let us see the elbow, what the findings will be. Here also, there is marked resorption of the lower end of the humerus, resorption of the ulna, look at the ulnar notch, huge, and resorption of the head of the radius. So with the findings that was found in the hip as well as in the elbow, there is no periostal reaction. Soft tissue swelling may be little. So in this particular case, what do you think of? Resorption or dissolution of the bones extending into the joints. Only one thing that we could think of. This is not arthritis, because supposing you get advanced rheumatoid arthritis, and then there will be some reactive sclerosis, soft tissue swelling. Although there is subluxation, but still it is not advanced rheumatoid arthritis or any other arthritis. It is a bone lesion extending into the joint. What could it be? One think of is Gorham syndrome. Another view of the elbow, noticing marked resorption of the bone is the salient feature. There is no fragmentation to think of a neuropathic type of joint. There is no discombobulation of the joint. Only dislocation of the joint is there, not soft tissue calcifications, not soft tissue swelling. In the skull, there is not much. There is only slight prominence of the vascular grooves, but there is no definite radiological finding. Again, when you come to the wrist, there is a dissolution of the articular margins of the corpus. The bones are small, as though they are partially resorbed symmetrically. And there is, of course, a dislocation at the radioulnar joint. With these findings, as we have said earlier, only we can think of Gorham syndrome or vanishing bone disease. The etiology, we don't know. Let us see. First case was reported by Jackson in 1838. Spontaneous resorption of bone. No stimulus, no fracture, no inflammation, no neoplasm. Gorham, 1955, described it as massive osteolysis. Tendency to involve adjacent bones. You have seen the elbow joint or hip joint. To begin with, there will be just only osteopenia and multiple radiolucent foci. Eventually, they resorb the bone. Cortical erosion and soft tissue mass may be seen. This is also called vanishing bone disease. So that is the first case. Gorham's disease, though unusual, one has to recognize. Of course, clinical findings will say that there is only disability but no inflammation or loss of weight or any other findings to think of a neoplasm or infective disease. This one, 67-year-old with chronic diabetes and slowly growing swelling of the foot. Chronic diabetes and of course swelling of the foot. Clinically you could see it's nodular type of swelling of the foot, not just edema. This is the radiology of the foot. What do you find? Well, this is a rather not a penetrating film, but still to find out the soft tissue lobulated nodular masses. Could be Kaposi sarcoma, could be neurofibromatosis. Let us see. In the lateral view also you could see nodular lobulated soft tissue mass. This is soft tissue film. That's why you don't see the bones. To bring out the soft tissue masses, this particular technique is used. Now, if you look at the leg, the bones, both legs, the bones show multiple small punched out areas with sclerosis and periosteal reaction involving both lower ends of the tibia and fibula. Once again, see those punched out areas have got a sclerosing margin. That gives a clue. Could it be osteomyelitis? Not much. If it is osteomyelitis, is it acute? No, there is no thin periosteal reaction. Is it subacute? Well, those small lucencies may indicate subacute process, but then it's not chronic because there are no sequestra that we could see. Madurai. Madurai is a small town. Of course, it's a religious center in Tamil Nadu district. And then, why did I show this to you? To give an indication for the diagnosis. This is also called Madurai foot. In the last half of the 19th century, one British Army officer, medical officer, has seen hundreds of cases and then he amputated them, telling there is a foot tumor. But of course, today we know there's an infection, it need not be amputated. And the organism is actinomycosis israeli. It is a bacterium, not really a fungus, but it behaves like a fungus. Another case, clinically, multiple sinus tracts are seen, induration, swelling of the foot. It is quite different from the previous film. There it showed multiple nodules, hypertrophied nodules. Here, multiple ulcerations and sinus tracts. This is the film, classical of a Madurai foot. Although actinomycosis is implicated, there are several fungi that are involved in this process. Here, diffuse sclerosis is most important, discombobulation is most important of the joints, and at the same time, multiple punched out areas with sclerosis surrounding it. That means it has been growing on for a long time with some sinus tracts, maybe secondary infection through the sinus tracts. That's why there's marked sclerosis and periosteal reaction of the bones. Fungal infections, directly you can take a smear or culture. This is what I was telling. These mycelia are branching, looking like a fungus. But these are actinomycosis bacteria, Israeli type. Mycetoma, as I said earlier, there are several fungi that are involved. Streptomyces, Streptomyces paraguayensis, Streptomyces pelletieri, Nocardia brasiliensis. All these may combine at times. It may not be one organism. And depending upon the color of the granules that exude from the sinus tracts, you might say white means streptomyces, black means pargualeriasis, red means, like that you can actually tell the microscopy of the fungus. Again, typical example of a fungus lesion involving the tarsus and metatarsus, multiple punched out areas with irregular periosteal type of reaction, also sclerosis surrounding these lucent areas. A 42-year-old man complains of pain in the feet, both feet. And then if you look at the films, AP of both feet, you can see there is mild narrowing of the joint space, reactive sclerosis associated with erosions. Periosteal reaction, none. So the major finding is lucencies, reactive sclerosis, and joint space narrowing. There is no para-articular osteoporosis. That gives you a clue that's not an acute inflammatory type of disease or infective type of disease. No periosteal reaction either. And then if you look at some of those, especially on your left, first metatarsal head, on the medial side, there is a punched out area with overhanging margins. That gives you a clue that it must be gout. But then gout, cartilage is relatively spared most of the time. But then occasionally, in advanced cases, you may get degenerative joint changes. In fact, we have seen cases where the diagnosis is made degenerative arthritis. It is only secondary to the gout. Medical knowledge, you know, doubles every decade. Another case of gout with a soft tissue tophus in the olecranon bursa. Sometimes these tophi may calcify. And the crystal deposition is monosodium urate crystals. Occasionally they may calcify and produce calcific tophi. Look at the hand. Metacarpal head, eccentric type of erosion with the overhang margin and no real para-articular osteoporosis, typical of gout. Another tophaceous gout, soft tissue swelling, irregular calcification, bony reaction, relative preservation of the joint space cartilage. In advanced cases only that gets atrophied or destroyed. Years ago, this historical Napoleon has got it. I believe Julius Caesar also had it. Like that, historical figures had gout. And in those days, they used to give punch in the 18th century. Gout, what are the radiological, to recapitulate what the radiological findings are, lack of osteoporosis. Lack of osteoporosis? No, generalized osteoporosis you may get because of the age factor. But lack of para-articular osteoporosis, subchondral erosions, we have mentioned already, extra-articular erosions, not only along the joint, but in the metatarsal shaft also may get erosions. Eccentric erosions with overhanging margins, that is typical. And then pseudotumors, occasionally you may get in the bone itself, cystic type of lesion because of the gouty deposits and may simulate a pseudotumor. Reactive new bone is present. Secondary degenerative changes, as I said, in the joint because lately it involves the cartilage. And then, of course, infarcts because of these urate crystal deposits in the vessels, small vessels, you may get bone infarcts. And calcified tophi also are present. Although generally seen in men, occasionally in postmenopausal women or alcoholic women, you may get gout also. This 28-year-old woman complains of pain in the left chest. What you see is a big soft tissue mass superimposed over the chest. Is it in the lung? Is it in the pleura? Is it in the mediastinum? Or is it in the bone? From these films, it may be hard to tell. But then in the lateral also, obviously it is posteriorly located. It is not involving the sternum or any other structures anteriorly. It is not from the heart, so it must be from the mediastinum. And then, if you look at carefully, this penetrated view shows some of the ribs, especially the fourth rib is eroded, and the anterior part of it is not seen. Even this mass has got a slight calcific rim. Unless you see closely, it may not be possible to observe this. So a calcific rim, erosion of the ribs. If it is the erosion of the ribs, it could be neurofibroma because it is arising from the posterior mediastinum. But there is a calcific rim. Neurofibromata does not calcify, nor schwannomas. Let us proceed with a CT. Here we are. Again, you see multiple bony septae, multiple lucencies in the again posterior mediastinum with erosion of the rib. Another, this classically shows calcifications, also not only along the rim, in the center, ossifications, and fluid levels. If you look carefully in the multiple fluid levels, that indicates that it must be an aneurysmal bone cyst arising from the rib. It's hard to know just from PA and lateral views. You have to have a penetrative view or a CT. You don't need MRI and all that just to show the fluid levels. And fluid levels are not specific for aneurysmal bone cyst only. Aneurysmal bone cyst could be primary is a primary aneurysmal bone cyst, and about 50% of the aneurysmal bone cysts may be secondary. Secondary to what? A giant cell tumor, for example, the chondroblastoma, osteoblastoma, fibrous dysplasia, telangiectatic osteosarcoma, chondromyxoid fibroma, and there are several others. That is superimposed aneurysmal bone cyst. In fact, the pathologists, if they take a biopsy from the aneurysmal bone cyst, they will just say aneurysmal bone cyst. Unless the entire resected specimen is examined, you won't know what the underlying pathology or underlying the primary tumor is. Expansile radiologically, lytic lesion containing cavernous blood-filled spaces. Pathologically, you could see blood-filled spaces and numerous giant cells. As opposed to a simple bone cyst that you see in the long bones, this grows horizontally. That's how you differentiate from a simple bone cyst, goes vertically along the shaft, whereas this one grows horizontally. That is the major differentiation. Of course, CT shows fluid levels which are characteristic, although these may be seen in other entities also, as we have mentioned earlier. This particular man, 30-year-old, with history of swelling of the left shoulder. Little pain is there, but most important is the swelling. You see the plain films of the shoulder, you might find out a soft tissue swelling. No characteristic. It's not a lipoma, it's not lucent, it is dense. So some soft tissue swelling is there. No bony erosion, neither the acromion, nor the head of the humerus, nor the neck of the humerus. There is no bony erosion at all. So ultrasound, to know whether it is solid or cystic. You find multiple rounded or oval lucent areas or lower echo areas with echogenic rim, indicating that may be a fibrous tissue or a capsule or a calcium. Obvious, the MRI shows soft tissue swelling and then multiple melanocyte type of densities that you could see, characteristic of tuberculous bursitis. There is fluid, there is annual reaction, and these are the hypertrophied, shredded synovial melanocyte bodies. Sometimes you may see tuberculous organisms also in these, classical of tuberculous bursitis. Differential diagnosis could be rheumatoid arthritis, soft tissue swelling, synovitis, or osteochondromatosis before it calcifies. On plain film, they may not calcify, and then if you take CT, it shows multiple calcific densities. PBNS, pigmented villonodular synovitis, but then there should be erosion of the bone. Here the bone is not involved. Often in pigmented villonodular synovitis, apart from the soft tissue swelling, adjacent bone may be eroded, adjacent articular margin may be eroded. And then of course amyloidosis. At this young age you don't think of primary amyloidosis or secondary amyloidosis, but there is no osteoporosis in plain films. And then no bony lesion actually. Now 24 years old man with heaviness in the lower part of the thigh, comes just a heaviness. And then AP and lateral views, what do you find? It's not a spot diagnosis, immediately you can jump. You may think paraosteal osteosarcoma, but there's lucent areas around the ossific densities or calcific densities. And even in the lateral view, it is multiple calcific densities, and you see a lucent areas around it. This shows much better, a lateral view, focused. Look at the rounded lucency as if there is lipoma. But then what are these hyperostosis and calcific densities doing? So if you correlate both radiological features, lipomatous tissue, calcifications, ossifications, and the bone exactly is not that much involved. Again, MRI, same thing, fat with high signal intensity, and then you could see a mass with multiple low intensity signals. Again, same case, showing the lipomatous tissue. On CT, you could see better, probably, cross sections. Diagnosis, paraosteal lipoma. There's an entity called paraosteal lipoma. age is generally less than 35 years, non-tender mass, fixed to the bone, focal hyperostosis and calcification also, or ossification, is described much better by Jacobs in 1972. Since then, occasionally we see a case of this sort. AP view of the thigh, again showing the large lucent area, lipomatous tissue, and hyperostosis. Angiogram doesn't help much because there is no angiomatous type of lesion. It is not a hamartoma. It is clear-cut paraosteal lipoma. Lipomas can occur in soft tissues, in intestinal tract also, paraosteal region, that which we saw. Intraosseous lipomas can exist. Sometimes they may calcify because of the fatty degeneration. And then hemangiolipoma, we know in the vertebra, most of the hemangiomas do contain some lipomatous tissue. That we know by MRI studies.